because there should not be any back.
പുതുമണ്ണിന്റെ ഏതാണ്ട് കഴിഞ്ഞ ദിവസം പറയുന്നുണ്ട് പഴയ മണം.
Kindly, there's one more. I'm requesting all the participants to kindly keep yourself muted, except for the examiners and the presenter. Hashim, kindly ensure that. Okay, it's 7:30 and we will be starting up. We are starting up with the proceedings. So good evening all. Good evening on behalf of Ampok. As you all know, today we are having our 9th edition of case presentation, which Ampok has been initiating. So we have been getting very good response from across the country for this initiative which we have taken, and special thanks I would like to mention to Dr. Sujit because he is associated with the young medical oncologist of the ISMBO. So without wasting much time, I request Arun Chandrasekhar to take over the proceedings to welcome the examiners and the presenter and take up the proceedings. Over to you, Dr. Arun.
Yeah, thank you, sir. Good evening, everyone. So on the behalf of Ampok, welcome to everyone for our monthly case presentation. Thanks to Sujit again for making this have a more widespread reach. So today we have Dr. Nazneen from Lakeshore, who will be going through a lung cancer case. And we have two very eminent external examiners, Dr. Anup from RCC Trivandrum and the Regional Cancer Center in Trivandrum, and Dr. Ashok from Aster Medicity in Cochin. So I think we'll hand the dice on to the examiners. So I request Dr. Anup to take over and you can ask the presenter to start presenting.
Thank you, Arun. Dr. Nazneen will be presenting the case of lung cancer. Please. Over to you, Nazneen.
Shall I start, sir?
Yeah, sure.
60-year-old male hailing from Kasaragod, who's a retired headmaster, presented with chief complaints of dry cough 3 months duration, breathlessness 1.5 months duration.
Doctor, can you make the presentation full screen? We can't hear you.
Nazneen, you are not audible. Kindly make your presentation in the presentation mode.
Hashim, is Dr. Nazneen online?
There's some issue with the network. I just spoke with Hashim. There is some issue in the network. He is communicating with her. So hopefully we should be able to rectify it soon. I think 2 instruments were checked. She logged in from 2 instruments. So there was echoing was there. So it seemed like network.
Yeah, I think so. Last time also there was an issue with the network from our side during the journal club.
Okay.
Let's see.
Sure.
Um, Sir, shall I start once again?
Yeah, sure. Please.
Can you put it in presenter mode in the full screen? Thank you.
60-year-old male hailing from Kasaragod, who is a retired headmaster, presented with chief complaints of dry cough of 3 months duration, breathlessness of 1.5 months duration. History of presenting illness. Patient complains of dry cough of 3 months duration, not associated with any postural or diurnal variation. No history of hemoptysis. Patient developed breathlessness on exertion for last 1.5 months. Initially, he developed breathlessness on exertion and it gets relieved with rest. Later, it progressed over 1 month to breathlessness on walking at own pace. No postural or diurnal variation. No history of loss of weight or loss of appetite. No history of dysphagia, hoarseness of voice, facial swelling, chest pain, or pain radiating to arm. No history of recurrent respiratory infections or fever. No history of palpitation. No history of abdominal pain, distension, jaundice, or any swellings anywhere in the body. No history of headache, convulsion, bone pain, or symptoms suggestive of metastasis. Past history, no history of any similar illness in the past, no history of TB, bronchial asthma, or any other comorbidities. Personal history, he had a regular bowel and bladder habits, no additions. He had adequate sleep and appetite. He followed a mixed diet. Family history, his mother was diagnosed with lung cancer at age 70. No history of smokers in the family, no history of TB in the near family. Summary, 60-year-old male, non-smoker with no comorbidities with a family history of carcinoma lung in mother, presented with complaints of dry cough of 3 months and dyspnea of exertion of 1.5 months duration.
Okay, Nasreen. So this patient is having family with the family history of lung cancer, and now he present with cough and dyspnea. So what is your impression actually for this patient? 60-year-old non-smoker male patient. So are you in line with going for a carcinoma lung or some other diagnosis with this much history? So what is your impression regarding the symptomatology?
Since he had no history of fever or other productive cough, I go with the carcinoma lung as my first DED in this patient.
So what prompted you to say that it's a carcinoma lung in this summary? Just Just telling you that it's a case of lung for discussion. So
What
what all
sir is
points?
asking is,
What
Yeah.
all points? Yeah, to tell you that this patient is you are going for a diagnosis of carcinoma lung. Patient,
Cough and dyspnea.
60-year-old man with the cough and dyspnea. There are a lot of causes. You cannot say it's a lung cancer. You don't go for a lung cancer. If you are sitting in a general medicine OPD, you don't see, you don't have first diagnosis of lung cancer. No? So what is the importance of history of CA lung in the mother in this particular case? What is the significance of family history of lung cancer?
Sometimes in genetic polymorphisms in certain genes, like cytochrome P450 and which activate the toxins. Sometimes it may be seen familial, or some genes encoding the glutathione which deactivate the toxins. Such polymorphisms can be seen in the family. So there is a slight
Okay, there are a lot of
lung
meta-analysis.
cancer with
Yeah, there are different meta-analysis which showed that there is increased risk of lung cancer if you have a family history of lung cancer. Okay, and moreover, especially in patient with the carcinoma, there can be familial carcinoma, CA susceptibility symptoms, just like retinoblastoma. If you go for a life-from-money syndromes, these patients are particularly, you can have carcinoma lung, especially if the patient is a smoker. So if you have a family history, in this summary, the only point which favor is the family history of lung cancer in the mother. Okay. But then what are the other risk factors? You will ask. What are the other associations of lung cancer? So you have asked for history of pulmonary tuberculosis, bronchial asthma in the past history. So what is the importance of asking that history? Tuberculosis, bronchial asthma, COPD in lung cancer, pertaining to the lung cancer.
In patients exposed to smoking may have COPD.
Okay.
And also,
Yeah, you are right. Patient with the history of COPD, there is increased risk of CA lung, especially if the patient is a smoker. Okay. Then, what about pulmonary tuberculosis? And lung cancer. Lung cancer, patient with the pulmonary tuberculosis, you can have cavitary lesions. Okay. In long-standing cases, it can convert to a squamous cell carcinoma. There can be scars in the lung. It can turn into squamous cell carcinoma. Okay. So pulmonary tuberculosis, long-standing pulmonary tuberculosis, there you can get carcinoma lung. That is the importance of asking pulmonary tuberculosis. In terms with the carcinoma lung. Then what about pulmonary fibrosis? Pulmonary fibrosis also is a high risk factor for getting carcinoma lung. So these are the importance of asking family history, especially in patient with the carcinoma lung. Okay. Patient is a non-smoker. So something about smoking. Can you say what are the different types of smokers? Listening? Yeah.
Formers,
Hmm.
former smoker who have quit smoking for more than 1 year. Recent smoking who have quit smoking from 1 week to 1 year, and recent smoking who smokes at least 1 cigarette per day, and never smoking smokers who have not smoked 100 at least 100 cigarettes in their lifetime, and heavy smokers with more than 40 pack years.
40. Okay. What is pack years of smoking?
Number
you
of
calculate pack
packs
years?
per day. Number of packs per day smoked into number of years.
Number of packs of cigarettes smoked per day multiplied by number
Into
of years.
number of
Okay. Okay. Can you tell some of the malignancy, which are the malignancies associated with smoking?
cancers of oral cavity, pharyngeal cancers, bladder carcinoma, and,
Okay.
and ovary mucinous, and esophageal carcinoma.
Which hematological malignancy is associated with the smoking?
AML, benzene
Acute
associated.
myeloid leukemia. Yeah, very good.
AML.
Okay, what is second-hand smoke? What is second-hand smoke?
Those who get passive smoking, passively, those who get passive smoking from.
Okay, second-hand smoke is basically the smoke related with the environmental tobacco smoke, environmental passive smoking, or involuntary smoke. Okay. So have you asked for any history of cancer in this patient? What is the importance of asking history of cancer, especially in lung cancer cases?
I didn't get you. Cancer in lung cancer.
Yeah. So in the history, you will ask past history of any lung disease, any history of cancer. So what is the importance of asking history of cancer, especially in patient with the lung cancer, when you take a history for lung cancer?
Patients have received previous RT to.
Very good. Yeah. Yeah. So patient with the history of chest radiation, you can have second malignancy. You can present at the carcinoma lung. Then what about small cell lung cancer? Asking history of small cell lung cancer in the patient. What is the importance? So in patient with the small cell lung cancer, there is threefold increase in risk of second primary lung cancer. Okay, if you have a small cell lung cancer, there is high risk for a second malignancy lung cancer. That is important. Then especially in lymphosarcoma patients, there is always treated patients, you can have history of high risk for carcinoma. Then so patient history of, if you have a head and neck malignancy, history of especially like hypopharyngeal carcinomas and laryngeal carcinomas, there is high risk for a second primary in the lung. So if you have a history, if you are asking history of cancer, these should be in mind. Okay, that is the importance of asking family importance of cancer in the history. Okay.
Dr. Nasneen, do you think this patient has small cell lung cancer?
No, sir. He's a non-smoker.
Why? Right. So I think, like sir said, I think you should not restrict your diagnosis to malignancy alone with this history, I think you should at least include other possibilities like COPD, late onset bronchial asthma, and so on. I don't agree with your single diagnosis with no differentials. But I agree that I can accept it as the primary professional diagnosis, but there should be a differential to this. There is nothing in the clinical symptomatology that points to specifically and exclusively to lung cancer. Okay. I think you can go on.
General examination is conscious oriented with peacock performance status 1, moderately built and nourished, with height 169 centimeter, weight 60 kg, BSA 1.67. Pallor was present, and there was no interest, clubbing, or cyanosis. Right supraclavicular lymph node of 1.5 to 1.5 centimeter was palpable, which was non-tender and hard in consistency and mobile. There was no generalized lymphadenopathy. BP was 120/84 millimeters of mercury measured in the right upper arm in sitting position. Pulse 82 per minute, respiratory rate 18 per minute, abdominothoracic, febrile. Respiratory system examination, upper respiratory tract, ear, nose, all normal, oral cavity, oral hygiene maintained, no caries, no nicotine stains. Respiratory rate 18 per minute, abdominothoracic, just wall movements were diminished on right side, no supraclavicular hollowing or fullness seen, no drooping of shoulders, no upper limb edema, skin over the chest wall were normal, no scar sinuses, dilated veins over the chest wall. On palpation, no local rise in temperature or tenderness. Trachea shifted to left, apex beat not palpable. Chest movements reduced on right side. Chest expansion was 2.5 centimeter, right 1 hemithorax 1 centimeter, and left 1.5 centimeter. AP diameter was 23, transverse diameter was 32 centimeters. Spino-scapular distance on both the sides were 8 centimeter. Vocal fremitus was decreased on right side. On percussion, dullness felt in the right inframammary, axillary, infraaxillary, infrascapular area. Tidal percussion was negative. Auscultation, breath sounds were reduced in intensity on right side on all areas, and absent breath sounds on infrascapular and inferior axillary area. Normal vesicular breath sounds were heard on the left side. Vocal resonance was decreased on all areas on right side and absent in right infraaxillary and infrascapular area. Spine, there was no tenderness, skull, no swelling, serious S1, S2 heard, no murmur, CNS, no vocal neurological deficit, per abdomen was soft, no organomegaly, per rectal examination not done. Summary, a 60-year-old male non-smoker with a family history of carcinoma lung in mother with no comorbidities, presenting with complaints of dry cough of 3 months duration and progressively increasing dyspnea of 1.5 months duration, with a right supraclavicular lymph node and right pleural effusion.
So how you are going to proceed in this patient?
I would like to do routine blood investigations like CBC, LFT, RFT, ultralights, and diagnostic investigation like supraclavicular lymph node biopsy and staging work, PET-CT, and pleural fluid, the pleural fluid cytology, cell block, and pleural fluid tapping. Patient is symptomatic.
Any
So
other imaging?
MRI brain also.
Okay. Dr.
So, yeah. So this patient, you first thing you are going to do in this patient is having anemia. In the investigation part, you showed there is anemia. Why anemia in this patient? The previous slide which showed there was pallor was there, no? Clinically pallor was there.
Yes.
So what was the hemoglobin in this patient? Normal. Clinically, there was
9.
pallor. 9. Okay. Okay. So first thing you are going to do is this patient is symptomatic. He presented with breathlessness. Initially started with the cough and later patient symptomatically with the breathlessness. So first thing you are going to do is you are going to do a pleural tapping in this patient. Is enough. Okay. Rather than going for imaging, if you take a, first of all, whenever you come across a patient with a dyspnea, just take a chest X-ray, just look at what it is, whether it is a right pleural effusion, whether it is a pericardial effusion, right? So this patient is having right side of pleural effusion. So you are going to do right pleural fluid analysis. What all things will you do in this patient? The pleural fluid.
Pleural fluid, LDH levels, TCDC, and protein levels.
Okay.
And
Then
to
what
know
about
whether
cytology?
pleural fluid is
The most important thing you should go for a cytology, isn't it?
Yes, sir.
Just cytology
Cytology plus
only,
cell
or
block.
some yeah, you should go for a cytology with the cell block, because you need to do so many other tests. You should go for immunohistochemistry, isn't it? So what all basic immunohistochemistry you will look into this? So this patient, your diagnose, the initial diagnosis from the cytology is adenocarcinoma. So what all thing tests you are going to do in this patient? So you get a pleural fluid cytology with the cell block. It shows that there is adenocarcinoma infiltration. What are the basic other tests? What all immunohistochemistry you will put?
Basic TTF1 napsin is present for lung, showing a glandular morphology. Then we'll put TTF1 and napsin.
Suppose your pathologist say that it is TTF1 is negative and napsin is negative. You get a polydifferential carcinoma and TTF1 is negative and napsin is negative. What is the other IHC will put?
It's morphology wise, it is adenocarcinoma. Then we can put CDX2 or mu staining and
Suppose it is not adenocarcinoma, it's a poorly differentiated carcinoma. Suppose it is not adenocarcinoma, it is poorly differentiated carcinoma. TTF1 is negative, napsin is negative.
we can put CK7 and P40.
So you should go for a P40. And suppose it's P40 is negative. Why you want to put P40?
Why do you want P40?
Yeah.
Squamous.
Yeah.
Squamous histology.
Yeah.
Squamous histology to roll.
Yeah.
That's it.
Yeah, P40, it signifies just squamous cell carcinoma.
See, suppose the patient comes, like sir said, it's a poorly differentiated carcinoma. The patient is poor. This is a situation we encounter quite often. And as you know, the number of markers, more you do, the more expensive it's going to be. For example, if you do 6 markers, it can cost upwards of 6,000, 7,000 rupees. So to take that into consideration, and I'm telling you, you can do 3 markers. It is a poorly differentiated carcinoma. From a, say there is a primary in the right upper lobe, and you've taken a biopsy from that. The scan is also suggestive of a primary lung cancer. I'm asking you to do 3 markers. Which 3 will you do?
TTF, P40 and neuroendocrine markers.
No, napsin. Okay, so CAP guidelines suggest that if you have a CA lung, a suspected CA lung, the bare minimum markers that you can do is TTF1, napsin A, and P40. So these are the three bare minimum that you have to do. You just have to keep that in mind. Everything else comes after that. You can get CK7 positive, CK20 negative. You can do CDX, neurophysin, synaptophysin, all those markers later. But the bare minimum is these three. Right. So where will you take the biopsy from in this case?
In
Suppose you do a PET
this
scan.
case,
You see that
he
there
has
is a right upper lobe mass. He has a right upper lobe mass, multiple mediastinal nodes. There is a liver lesion with a significant SUV. Mediastinal nodes are there. And you have the clinically palpable supraclavicular. From where will you take the biopsy?
supraclavicular node.
Right. Okay.
It is easily
So,
accessible.
yeah. So the most easily accessible site you will use to take the biopsy. And then you'll do your IHC. You've got your reports. Now you have a non-small cell lung cancer, adenocarcinoma. You have done the staging also. So for all, for it from the staging that I just mentioned, do you have the staging for this patient? Do you have the reports or something?
He had a bilateral lung nodules and
Okay.
supraclavicular pleural effusion came as positive for carcinomatous cells. Pleural cytology was positive.
Right. So, so this is a stage 4 NSCLC. MRI brain was done.
Yeah. No, it was
Okay.
not done. Else in fact, it was checked. It was nice.
It's okay, but I'm sure you know that as per NCCN guidelines, you should do an MRI brain from baseline. Would you do a mediastinal nodal staging for this patient?
This is a stage 4 disease, so I don't do a mediastinal staging.
Fine.
Invasive mediastinal staging in this case.
Okay. So at this point of time, what you have got your diagnosis, you have got your IHC, you've got your PET scan. Next, what are you going to do?
Patient is symptomatic. We have done a pleural fluid tapping. Then we have to send, since he's a non-smoker, I would send for NGS in
Okay.
this patient.
So what are the NGS markers, molecular markers that you want to look for?
According to ASCO 2022 CAP guidelines update, we look for EGFR, ALK-ROS, BRAF, and PDL1. First, it should be done, and in later
Okay.
stage, her can be done.
Right. So you have sent for this. Are you going to wait for the report?
Yes.
So you will wait for 3
I-
weeks till the report comes.
No.
Patient is having dyspnea.
Now, can't wait for 3 weeks. If patient is symptomatic, can start on chemotherapy.
You said that he is symptomatic. We are talking about your own patient. He is symptomatic. He has a right pleural effusion and he is having dyspnea.
After tapping, if he's able to, yeah, if it's symptomatic, we'll start on chemotherapy
Okay.
initially.
What chemotherapy you want to start?
Since it is adenocarcinoma histology, I would like to start on cisplatin pemetrexed based platinum doublet based chemotherapy.
Okay. Is there any preference between cisplatin and carboplatin?
In metastatic stage, only marginal benefit with the cisplatin compared to carboplatin. So We look into performance status, and carboplatin pemetrexed is also equally good. But
Yeah.
there is a marginal versus platin.
There is a significant, statistically significant difference between cisplatin and carboplatin. Are you sure? Okay, so there's a
Subgroup
meta-analysis.
analysis have shown
There is a meta-analysis called CISCA, CISCA. You can read that. So what it says is the overall response rate is better with cisplatin, but the survival rates are only marginally better, like you said, but was not statistically significant. And for all practical purposes, considering age, performance state, like you said, age, performance status, and the toxicity profile, for all practical purposes, carboplatin can be used instead of cisplatin in almost all cases. Okay, so there is no statistically significant difference in survival between cisplatin and carboplatin. However, there is a very large difference in the toxicity profile. Why are you using pemetrexed?
in adenocarcinoma, pemetrexed has shown a superiority over when cispam was compared to cisgem. Cispemetrexed was superior in adenocarcinoma in terms of survival.
Do you know the
And
trial?
also JMD. JMD.
Okay. So why does pemetrexed work better in adenocarcinoma and it doesn't work that well in squamous?
Because in adenocarcinoma, some MTAP gene deletion frequency is high, and this gene is responsible for curing.
It's not that complicated. It's not that complicated. Okay. Gemcitabine is what is gemcitabine? It's a DNA polymerase inhibitor. Pemetrexed is a folate antagonist. Thymidine synthase, DHFR, and some ribonucleotide something is what it inhibits. That is why we give folic acid and methylcobalamin before we give pemetrexed. Okay. The thymidine synthase is more, the mRNA for thymidine synthase is more expressed in squamous cell carcinoma, which is why it is more resistant to pemetrexed as compared to squamous. Okay. So you started on pemcarbo. Your reports came. So this patient is EGFR positive. What more would you like to know?
I would like to know which exon EGFR is positive, exon 18, 19, or 20 or 21. I would like to know that.
So this is a deletion 19.
Then we could start with EGFR tyrosine kinase inhibitor. I prefer osimertinib in this patient.
When will you start? Now you have finished first cycle. Second cycle is due in 2 days. Will you start osimertinib with pemetrexed? Pemetrexed cisplatin?
Ideally, there are two options. We can continue the planned cycles of chemotherapy and then start osimertinib, or interrupt and give osimertinib.
Is that what NCCN says?
And giving osimertinib
is that what NCCN says?
NCCN says to interrupt and start the osimertinib is preferred, but you can continue for up to 4 cycles. Continue therapy and proceed, give maintenance, and then start when.
The last I checked, for all the mutations, all the oral TKI mutations, it is given in 2 divisions. If you have already started systemic therapy, it is better to complete it and go for switch maintenance. There are 2 types of maintenance: continuation maintenance and switch maintenance. So after 4 to 6 cycles, you can switch to the TKI that is available for that targeted mutation. So I think that would be the preferable option rather than stopping the chemotherapy at that point of time. Suppose this patient cannot afford osimertinib. What is the next best choice you can give? Is there any data to
Mm.
suggest that we can give, say, a first generation TKI along with chemotherapy, which improves PFS and OS for those patients? It is not very far away in America. It is in India only.
We can give chemotherapy with TK also.
Yeah. Do you know the trial, the data from where it is?
Trial is there.
Which one?
TMH data is there.
Yeah. Right. So it was presented in ASCO 2020, I believe. At that time, they had shown that there's a clear survival benefit when you start chemotherapy and add on Geftinib. So the treatment was Geftinib Pem-Carbo for 4 cycles, and then they do maintenance with. So you finish that. What do you give maintenance with that for that patient? Is it going to be Geftinib or Pemetrexed or both, or you'll switch to a third line agent? What would you prefer?
Geftinib maintenance.
So go read that trial.
Or
What they
both.
did was they gave Pemetrexed plus Geftinib maintenance. Okay. Sir, Dr.
Yeah.
Anup,
Yeah, Nasreen, what are the different types of maintenance treatment in lung cancer? Can you define?
Maintenance chemotherapy is there with the pemetrexed until disease progression, and maintenance bevacizumab in adenocarcinoma showed a PFS benefit, and maintenance in PD-L1 positive tumors, maintenance with immunotherapy is also an option.
Yeah, what about switch maintenance? You are discussed about the continuation maintenance. Okay, what is switch maintenance? Which drug is used as switch maintenance in adenocarcinoma? Switch maintenance, you can consider Pemetrexed. If you started with the Paclitaxel, you can suppose this patient Paclitaxel, you can just convert it to switch maintenance with the Pemetrexed. Okay, so all other options are continuation maintenance. Okay. Suppose you continue with the Pemetrexed in this patient, maintenance. Then how you are going to follow up this patient?
That to take a 3-monthly CT scan to look for the response rate in this patient, and also
Yeah.
become symptomatic.
More than response,
redo.
more than response, Nasreen, more than response. You're giving Pemetrexed as a maintenance treatment. So most important thing what you expect is more side effects rather than relapse. Okay, so the monitoring your side effects is the most important thing in this patient. So what are the toxicities related with the Pemetrexed? What are toxicity we can get with the Pemetrexed?
Skin toxicity will be there.
Yeah, common toxicity you come across in your wards.
Mucositis, myelosuppression, and
Okay.
the skin toxicity.
Skin toxicity. What
like
skin toxicity you can get?
Hyperpigmentation,
Hyperpigmentation, rash,
acne from rash.
erythrosis, photosensitivity.
recommendation.
Hmm.
And
Okay, how you give Pemetrexed? How you administer Pemetrexed?
pemetrexed in 100 ml NS over 15 to 30 minutes.
30 minutes. Is it 30 minutes?
30 minutes.
Is it?
15 minutes.
Hmm?
15 minutes. 15 to 30 minutes.
No,
2 minutes.
it's 10
Really
minutes.
10 minutes infusion. It's a short infusion, 10 minutes. Okay.
So how will you write a prescription? Just can you tell? What are the other drugs that you will give? What is the emetogenic potential?
To prevent the skin toxicity, we give Dexa. Injection Dexa, normally 8 mg, and injection Daso, and Emicit also.
How much? What is the emetogenic potential of pemetrexed carboplatin?
Carboplatin is UC5 is moderately emetogenic. So,
Okay, so this is moderately emetogenic, right? So other drugs, you have to give some other things when you give pemetrexed.
Dexaraso and Emicit.
That's all.
And
You will not give anything else. Then this patient will definitely have skin toxicity.
I will.
I will. We discussed this little before. 2 more things that we give, no? Pemetrexed, specifically for pemetrexed.
The vitamin B2 folic acid that will start folic acid vitamin
Yeah, you have to
1
tell that.
week before giving
How much?
pemetrexed.
How much and when?
1 week before starting pemetrexed, we have to give vitamin B12 500 microgram and folic acid 1 mg OD daily, 5 mg OD daily.
Okay, folic acid 5 mg OD daily. How much of vitamin B12 you will give?
1000 micro.
Yeah, so you said 500 now. 500 is not correct.
What
Do
is
you
the
know?
interval?
After 6 weeks, we have to repeat it. Vitamin B12
Are you sure?
injection. Yeah.
Suppose this patient develops, before that, what are the drugs that should be avoided when you give Pemetrexed? Some particular drugs which we should avoid when you give Pemetrexed. Which are the drugs? Very common drugs should be. Nestle?
Okay. Then I don't remember.
What toxicity you are expecting with the Pemetrexed? So this patient, most of the patient with the advanced lung cancer will be in pain, will be associated with very painful metastasis. So naturally, this patient will be getting pain medications. So what all things you look in the medications chart? Yeah, you should.
Ibuprofen is avoided.
Yeah, you should avoid ibuprofen or NSAIDs. Okay, there is high chance of drug-induced renal failure if you give NSAID along with the Pemetrexed. Then drugs like proton pump inhibitors, then penicillins, cloxacillin, etc. There are high chance of renal failure when you give other nephrotoxic drugs. So you should avoid all this. Okay, it's very common. Patient develops renal failure after 1 or 2 months after starting Pemetrexed. Okay, it more commonly it may be due to associated drugs rather than chemotherapy. So you should avoid that. Okay. Suppose this patient progresses on pemetrexed. What are the other options?
If he does progress, will you take a rebiopsy?
Yeah.
Yes, sir.
Okay. So do you want a tissue biopsy or liquid biopsy?
Any easily accessible tissues there, then tissue biopsy. If patient is not willing or there is no accessible site, then liquid biopsy is also good.
Okay. So once you've done the biopsy, let's consider that this patient was, like you said, it was initially it was you started on pemetrexed carboplatin. The PDL1 was low. We have not talked about PDL1 at all. So let's say that when you started the chemotherapy, the PDL1 came as say 20%. So you would add an immunotherapy to the chemotherapy regimen, right?
Chemoimmunotherapy can be given.
Okay. So suppose it's less, let's consider that it is less than 1 for the time being. Okay. PDL1 is less than 1. So you have not given immunotherapy. You have given only PEM carbo and you have given PEM maintenance and the patient has progressed. Now a new liver lesion has come. You have taken a biopsy from there. What all will you do in that biopsy?
GFR.
We can look for the
People are prompting you. Go ahead.
mutation status. Then PDL1 also can be checked.
Okay.
I'm not sure whether can be check PDL1.
Is it indicated?
No, no, I think.
So what are the other markers that you look for? See, the patient, let's consider that he is not a headmaster. He is a very rich person. And you have already sent a panel of NGS panel. You are told correctly, the ASCO endorsed CAP guidelines. You have to send ALK, EGFR, ALK, ROS1, BRAF, and PDL1 has been sent. So at this point of time, you will send the second line of the NGS panels if it has not been sent before. And those are
Rect, HER2, MET, KRAS, NTRK, and
okay.
PIK3C.
PIK3C is not there. Okay. PIK3C is not there. The rest of what you have said is correct. Is there anything else that you can do as a biomarker to offer him immunotherapy? In short, do you know any other biomarkers for immunotherapy?
Tumor mutation burden.
Okay. How much is
Tumor-
of tumor mutation burden will you consider adequate to offer immunotherapy?
More than 10 mutation per megabase.
Right. Okay. Many cutoffs are there. Some people say 10, some people say 15. No problem. Both answers will be accepted. Right. So you have done this mutation analysis and you have found that he has a MET mutation. Okay. So what will you do?
Then I would like to start on MET inhibitors like kappa-mat.
Straight away we'll start on MET inhibitors.
Mm.
So, so for all patients with a MET mutation, you will give MET inhibitor like capmatinib or tepotinib. Are you right? Are you correct? I mean, that's what. Is that what you're saying? Okay. So
Yeah.
what are the types of MET mutations?
Only if met amplified more than 5 copy number or met expand skipping mutation is there only we'll
Right.
start. Met amplification
So,
copy number you have to met 7 ratio have to be more than 5.
okay, so the trial is called geometry trial. You go and read it properly. What it says is capmatinib tepotinib is approved for MET exon 14 skipping mutation. That is the more common mutation is the MET amplification. When there is a MET amplification, like you said, we have to look at something called gene copy number. And as per that trial, what they have said is, if it is more than 10, there is some response to capmatinib, but not as good as if it was a exon 14 skipping mutation. Okay. So the answer to what I asked is, if it's a MET mutation, the first thing you ask is it a MET exon 14 skipping mutation? If it is not, and if it's an amplification, the next question you ask is if it is a gene, what is the gene copy number? If the gene copy number is more than 10, then you have to give, then you can give capmatinib or tepotinib. If it's less than 10, you have to give what?
Chemotherapy.
Yes, you have to give systemic therapy. In fact, there is, even if you have MET mutation in the beginning, you still start with systemic therapy and you leave the MET inhibitor for second line. Another thing, suppose you have a MET mutation, will you offer this patient immunotherapy? Suppose there is MET amplification, will you offer him immunotherapy? Second line, nivolumab, something like that.
Met amplified tumors are poor response to
Yes.
immunotherapy.
So most of the second line tests for lung cancer, be it MET, RET, HER2, whatever it is, all of them in general have poor responses to immunotherapy. Okay. So that's something you have to remember. And if it's a MET mutation, you have to give a MET inhibitor only in cases of exon 14 skipping mutation. That's all it's approved for. Off label, you can use it if the amplification with the gene copy number is more than 10. Right. So what chemotherapy will you give for this patient? Second line. None of this is positive, or he can't afford capmatinib.
Inline chemotherapy, docetaxel or vinorelbine is an option.
So mostly single line agents, right?
Yeah.
Okay. What are the options you said? Taxanes, vinorelbine.
Gemcitabine, if not given earlier.
Gemcitabine alone or with carboplatin?
Abogem.
Okay. Right. Right. So about liquid biopsy, what are the mutations that you can check in a liquid biopsy? What are the approved mutations that can be checked in a liquid biopsy?
EGFR, ALK, and EGFR, ALK, ROS can detect in liquid biopsy.
Ashok,
Yeah.
it's going to be it's almost going to be an hour.
Okay.
I think like this, we can.
Anup, sir.
I know if you have any further questions, I think like
Yeah.
beyond 1 hour, nobody should be grilled.
Yeah.
Even if it is a mock exam.
Okay. So should we? How much time we have, Boban?
One more question you can ask, and then we can wind up. You can give your comments, and then we'll close the session.
Okay.
I think Ashok was
Suppose-
asking about the liquid biopsy, so that can be continued. So that means like we have reached that.
No,
level.
sir. If Anup sir has something to ask, you can ask.
Nothing. No problem. I was just asking. Suppose this patient was started on osimertinib, and this patient has progressed. Okay, what are the other options in your pockets for this patient. Post-osmotic progression. Say in 2 to 3 words, 2 to 3 points.
Post-osmotic progression, so we have to first look the biopsy if there is any lineage plasticity to other histology, and after osmotic progression, chemotherapy is next line of management. Now,
Okay, what are the upcoming treatments in EGFR inhibitors other than osimertinib? Upcoming treatment options.
new third line EGFR inhibitors are being looked into, and
Osimertinib is third line only.
New third line laser rositinib.
Rositinib was taken off trial because it was found to be not effective. Rositinib is out. It was taken off trial a long time back when I was a student.
Combining EGFR with VEGF inhibitors ongoing. Flora 3 or
Yeah.
something.
Yeah, very good. You can combine
Combine
anti-VEGF treatment. You can strengthen the osimertinib with the anti-VEGF treatment. Okay. Then upcoming is the bispecific antibodies are coming up, combining with the lazertinib, third generation TKS. Okay. Can you say something about uncommon EGFR mutations? Which are the uncommon EGFR mutations?
Exon 20 insertions, ERBB2 mutations in the exon 20, and exon 20 insertion is not resistant to current EGFR inhibitors. We give systemic therapy, and second line as amivantamab, and other uncommon G719X, G76A mutation. For that, we prefer afatinib.
Oh my God.
Then
Yeah, we will stop, Baba. Yeah.
Right.
Yeah.
Yeah.
we give,
I think, okay, we had a very good discussion. That's the issue with lung cancer. There are so many points to be discussed, right from the history till the molecular biology, the newer drugs. So many things are there to be discussed. So lung cancer, definitely there's a very high possibility that we can get it as a main case also. So you had it was a very good discussion we had. So I request both the examiners to summarize your finding on the students, say some motivating comments, so that you will be prepared for the examination. The positives and negatives can both be discussed.
Yeah, Bhavan, thank you, Bhavan. I think in examination, actually, we have to concentrate more on common things and what we come across in our day-to-day practices, and common drugs, how to administer, what are the common side effects. All these things should be students should know. And in the examination, actually, they will ask only these basic questions only. They don't ask all the trials and benefits and PFS and oral survey, etc., etc. How you approach a case if you get a patient, and how simply you are going to manage this patient. That's how they are going to interpret you when you take a history and present the case. Okay, Nasreen.
Yeah, so I
What
think
about-
you're
yeah.
very well read. Your knowledge is quite adequate. I need to tell two things to the people here. One, don't think that lung cancer will not come as a case. Because when I went for my Adair interview, my case was actually a Pancreas tumor. So it can come for your final exam. That is possible. Don't forget it. So examination, of course, history and examination, please be very careful in both history and examination. Always better to give a wider provisional diagnosis than to stick to one diagnosis unless you are that sure that that is a diagnosis. Rest everything, whatever you say is fine. You should have some backing for it. Either it should be your in your guidelines, any of them, NCCN, ESMO, wherever it is, or you should have some trials to back it. Or if there are some areas of doubtfulness, for example, pemetrexed cisplatin versus pemetrexed carboplatin, you can easily say, in my institution, we give pemetrexed cisplatin, and that's the end of it. Everybody will accept it. So institutional protocol is also something that you can use. But overall, it's been done very well. And only one thing you mentioned, Flora 3. Please go read, because the place I work is a center for Flora 3 recruitment. It is for untreated EGFR, and it's the addition of osimertinib to pemcarbo in first line. Right, that's it.
Thank you, Anup and Dr. Ashok, for this, for being the examiners and asking very good questions, which is very practically relevant. I'm sure that the postgraduates across the country would have benefited out of this discussion. Now, request Arun Chandrasekhar to take out the proceedings and say the concluding remarks, and then we'll close out the session.
Thank you, sir. Thank you to both the examiners for a wonderful session, and thank you to Dr. Nazneen for giving us her time as well. So I hope it's been informative. So until next month, we'll have our next case presentation. So we'll pass the details in the next 2-3 weeks. And thank you once again to everyone who attended, and see you for the next one. Thank you.